validation of the HER2 rule to guide treatment duration for unprovoked venous thrombosis, the REVERSE-2 study. I'm presenting this on behalf of the REVERSE-2 study investigators. This study was funded by a French government grant and bioMérieux, who make the D-dimer that was used in this decision rule. Venous thromboembolism comprises deep vein thrombosis, which is a blood clot in a leg vein that causes leg pain, leg swelling. Blood clot can break off and go to the lungs, a process called pulmonary embolism. Venous thromboembolism is the second most common cardiovascular disorder, the third most common cause of cardiovascular death. Venous thromboembolism must be treated with short-term anticoagulants, 3 to 6 months. It's very clear that that saves lives. Thereafter, though, is a controversial and crucial question whether to continue anticoagulants. And venous thrombosis is categorized into provoked venous thrombosis, that is triggered, and unprovoked venous thrombosis that comes out of the blue. And the guidelines tell us that in unprovoked venous thrombosis patients, we should continue blood thinners lifelong. However, long-term follow-up studies of unprovoked venous thrombosis patients that have been untreated show us that less than 50% actually develop recurrent blood clots. So many patients continue on blood thinners needlessly. We aimed to develop a clinical decision rule or a scoring tool to be able to identify low-risk patients with unprovoked venous thrombosis who don't need to continue on anticoagulants. We did a gender-stratified analysis of a cohort study that we completed in 2008 and identified a decision rule entitled Men Continue and HER2. The HER2 points, which are applied in women, are for 4 criteria. One is HER, which is hyperpigmentation, edema, or redness of the leg. 1 for the D-dimer blood test, 1 for obesity, and 1 for older age. And men and women with 2 or more HER2 points had a 14% risk of recurrent blood clots in the year after stopping anticoagulants in our derivation study, whereas women with 0 or 1 HER2 points had a 1.6% risk of recurrent blood clots in the year after stopping the study, implying that they could stop their blood thinners. It's generally accepted that it's safe to discontinue if the risk after short-term anticoagulants are stopped in the following year is less than 5%. So the object of our presentation this afternoon is to demonstrate the validation of this decision rule. Decision rules, once they're developed, need to be validated before they're ready for prime time and ready for use by clinicians. So in a multinational, multi-center trial, we enrolled 2,779 patients in 44 centers in 7 countries. Between 5 to 12 months of anticoagulant therapy, we applied the Men Continue and HER2 rule. In men and high-risk women, we recommended that blood thinners be continued. In low-risk women, those with 0 or 1 HER2 points, per protocol, we stopped blood thinners. We then followed them for our primary outcome, which was recurrent blood clots in low-risk women who discontinue blood thinners. And this was ascertained through 6-month telephone follow-up and 1-year clinic visits to see if we were below that safe to discontinue threshold of 5% at 1 year. These are the main study results, and I'll focus in on the primary outcome group, which is the low-risk women, again with 0 or 1 HER2 points, who discontinued anticoagulants, and their risk of recurrence was 3%, with an upper bound of the 95% confidence interval of 4.8%. So in this large cohort study, the largest cohort study of unprovoked venous thrombosis ever conducted, we demonstrated that women with 0 or 1 HER2 points can safely stop blood thinners. This is an important finding because 50% of women with unprovoked blood clots can be spared the burdens, the costs, and the risks of lifelong anticoagulants. Thank you.
Thank you very much for this presentation. Professor Huber?
I think that's a very elegant method to find out who should can be discontinued, should continue with therapy. But for me, it's still not clear, should we do this test after 6 months, after 12 months, after 2 years? So you did it in a specific way, but what is the final conclusion with respect to discontinue in certain low-risk groups? At what time?
Yeah, so we applied our decision rule between 5 to 12 months in order to make it pragmatic. We derived the rule in patients that had been on anticoagulants for 5 to 7 months. We don't know how the rule will perform if it's applied at 3 months or 1 month or at the time of diagnosis. The most important predictor turned out to be the hyperpigmentation edema or redness. That may require time to develop. So we are sensitive to the fact that it needs to be applied where we applied it, between 5 to 12 months.
Maybe I didn't get it, but you have also D-dimer as a factor, as a variable. So what is the cutoff level for D-dimer if you do it, let's say, after 1 year or 2 years, if you apply this test?
Yeah, so in the D-dimer that was done as part of HER2 is done on anticoagulants, and it's at half the diagnostic threshold, 250 micrograms per liter. And again, it's applied between 5 to 12 months. And there is data that shows that D-dimer does decrease with time. So again, the time-sensitive potential is definitely there.
Sure. I'm not familiar with VTE too much. Can you just explain why it is that men have that higher risk of long-term events? And have there been ways to kind of stratify men into lower or higher risk?
Yeah, I'm sorry, fellas. We certainly did look long and hard at 69 predictors to identify predictors for low-risk men, and we could not. And it is a million-dollar question as to why men are higher risk. And there are many hypotheses, testosterone influence on the coagulation system, but nothing conclusive yet as to why they're higher risk.
Lynn Peterson at Trends in Medicine. So could you back it up a couple of slides to the full results? Yes.
Oh,
No.
Yep.
Right. So I'm missing something here, and I apologize, but so in the group of men and women together, it's 8.1 versus 1.6, whether you continue or discontinue. But in the low-risk women, it's still none versus 3. And the 3 is still even higher than your lowest risk of the other group. So why isn't it, you still want to continue them? You wouldn't have any VTE then.
Yeah, and that's largely a reflection of the fact that blood thinners or anticoagulants come with a major bleeding risk. And the major bleeding risk in anticoagulant-experienced patients is about 1 to 2% per year. And major bleeds are associated with case fatality rates 2 to 3-fold higher than venous thrombosis. So pound for pound, having a bleed leads to more death than venous thrombosis. So this criteria of 5% is safe to discontinue is based on projected long-term mortalities. If your 1-year risk of 5% of recurrence off of blood thinners, then long-term you're not going to benefit from being on anticoagulants. Now, a randomized trial would be the answer. However, they'd be exceedingly long to conduct because they'd be a lifelong decision that we're making here. It's important to recognize that in the high-risk group, the men and high-risk women, it was an observation-only study. So we recommended that they continue blood thinners, and the risk of recurrence in the continue blood thinner group was low because anticoagulants are just so effective. And the discontinued group really kind of reflects what the native risk is in the high-risk patients, and it was high. It was 8% per year, well above that 5% threshold.
There been any application of this when you go back and look at the approval trials for DVT for the factor 10As? Have you looked at that and analyzed it based on this?
Something we'd like to do, but have not done yet. But yes, it would suggest that there are low-risk patients that were enrolled in those trials, about a quarter of them that perhaps could have discontinued anticoagulants, but the retrospective scope is always 2020.
Ed Sussman with MedPage Today. I just want to get some clarification on what exactly are you measuring with the D-dimer test, and why is that so important in this?
Sure. So D-dimer is a marker of clot activation and clot dissolution. So presumably patients with higher native D-dimers on anticoagulants are still making clot, and that's the hypothesis as to why the D-dimer is a predictor of recurrence.
So lower D-dimer is better for you?
Yeah.
Just one last question, I guess, Dr. Rodgers. Front row here. What's the uptake of the algorithm in Canada? Is this widely used throughout the country at different hospitals?
It's just in its infancy because we haven't published the validation yet. We published the derivation in 2008, and we told folks to hang on. Derivation studies for decision rules are basically a hypothesis, and validation studies are proof that it works. So it hasn't been adopted, and that's what we're hoping for as a consequence of today's presentation.
And the last question?
Yeah, Social Letter France, Cardinal. A two-side question. Which kind of DVT did you include, proximal or even EP? And the second part of the question, did you perform any screening for etiology in these patients regarding cancer, regarding thrombophilia, etc.?
Yeah, merci. The first question, we only recruited patients with proximal deep vein thrombosis and segmental or greater pulmonary embolism. So we excluded the small clots, distal deep vein thrombosis and subsegmental pulmonary embolism. And the second question is we excluded patients with known cancer and known high-risk thrombophilias. We permitted patients with factor V Latin and prothrombin gene variant, but those with potent thrombophilias or combined thrombophilias were excluded, as were those with cancer.
Thank you. Just a clinical question here. You have a 64-and-a-half-year-old lady. She has 1 point, so you decide to put her off. Half a year later, she's at 2 points. Will you put her on again?
For future study.
Thank you. Okay. The next speaker.
All right, thank you.